everybody, welcome to this edition of 5 Minutes or Less of EMS. I'm your host, Kevin Mackey. We're coming to you today from the EMS division at Sacramento Metropolitan Fire District. And our guest today is Dr. Hernando Garzon. He's the medical director of Sacramento County EMS Agency. Welcome, Hernando.
Thank you, Kevin. Thanks for inviting me.
Absolutely. This is our second time together.
It is.
Last time we talked about spinal motion restriction.
Right.
Today's topic is about STEMI. First of all, just for some of the viewers who may not know what that is, can you just kind of go in, what is a STEMI?
A STEMI is an acronym for ST elevation MI, and it's something that we can diagnose by doing a 12-lead EKG and seeing ST elevations that are diagnostic of a heart attack.
Okay. Is that a small number or a pretty large number of the patients we take care of?
Well, overall, it's a small number, but we do see a lot of chest pain patients. So that is a large number. And those chest pain patients, sometimes it's obviously not cardiac, but many times it's suspicious for cardiac chest pain.
Okay. And as the medical director for the county, you've written policies kind of around when to use a 12-lead in chest pain patients. Can you kind of go through what kind of your intent is with that policy?
So for decades, we've had a EMS pre-hospital care policy for chest pain of suspected cardiac origin. But really, it's only been, well, maybe close to 15 years now, 10 or a little more, where we've actually been doing 12-lead EKGs in the field. And the distinction is that really any 911 receiving hospital should be able to evaluate and stabilize a chest pain patient. But we have found through specialty of care that only hospitals that can do emergent PCI, or not only those hospitals, but those hospitals are the best hospitals to actually treat ST elevation MIs. So with that data in our healthcare system going back 15 years, EMS started to selectively take heart attack or STEMI patients to specialty receiving hospitals, PCI centers that can do percutaneous coronary interventions. So the purpose of doing a 12-lead EKG is to take that subset of chest pain of suspected cardiac origin patients, and if we can diagnose them with an actual STEMI in the field with the 12-lead, then the destination becomes a PCI or STEMI facility.
I'm going to put my paramedic hat on and say, you know what? Not everyone presents with chest pain that's having a STEMI. Do you get worried that you're going to miss some of those?
A little bit, and actually our policy does call, so if you look at the 12-lead, the EKG policy, it gives you the other patients that you can consider doing a 12-lead EKG on. And the patients, the vast majority of patients with STEMIs actually do have chest pain. So we're going to catch most of them if we just did 12 leads on chest pain patients. But there are a couple of small subsets that we miss. Elderly patients, diabetic patients are classic for having what we call silent MIs, where they may just have shortness of breath, for example. Upper abdominal pain is sometimes the symptom patients experience when they have an inferior MI. Mm-hmm. So these are some of the other patients to consider doing a 12-lead EKG on.
Is the equipment sensitive enough to pick up what we're looking for?
Yeah, so there's two aspects about the equipment. One is just technically and operationally, how you do the 12-lead, where you put the leads, is the ambulance bumping up and down while you acquire the EKG, and what's the quality of the EKG. And that's important to talk about as well, and to make sure that we get the highest quality EKG so the interpretation is accurate. The second part of the equipment, as you said, is the software algorithms that go into interpreting that EKG. And when you have a good quality EKG, the algorithms are actually quite good. So with a STEMI, frequently they'll put 3 asterisks and say acute STEMI or acute MI, and then 3 asterisks at the end. Those are sort of to alert the person who's reading that EKG, the medic, that it is indeed a STEMI. So that's why the policy directs very specifically the language that you need to see from that algorithm interpretation to have it be one of those patients that we would divert to a STEMI center.
The policy calls out that the only patient that actually gets alerted at a STEMI receiving center is someone that it says star, 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 acute MI, star, 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 or star, 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 STEMI, star, star, star. We should not be alerting myocardial infarction of unknown origin or unknown age or things like that.
Correct.
Okay.
Yep. The reason we're doing 12 leads is to identify those chest pain patients and those subsets of a couple others that may have an acute STEMI, and it'll help with a destination decision, right? If it's a positive STEMI, it goes to a STEMI center. The next part of that algorithm for treating that patient, as you said, is the alert, and we have to be really clear on alerts in pre-hospital care, right? And this alert concept dates back to our trauma care that we've been doing for 40, 50 years in this country. That certain specialty centers and certain really critical patients, providing an alert to the receiving facility has the potential to have the receiving hospital activate resources in advance of patient arrival. So they can activate a trauma team, they can activate a cath lab, they can activate for a stroke patient, but that comes with consequences for the hospital. So our alerts have to be really accurate when we're actually calling alerts. And so a STEMI alert or a trauma alert are different than just a courtesy notification to a hospital that you have a certain kind of patient who's coming in and you want to give them a heads up. That usually does not trigger the utilization of resources.
Okay.
The algorithm for most hospitals that do not have emergent PCI capability is to stabilize the patient in the emergency department, sometimes give thrombolytics, and then they usually have agreements and contracts with STEMI hospitals to transfer that patient for a STEMI. So there may be an interfacility transfer that's indicated for that kind of patient who will go and get his emergent cath at another facility. So that care is available at non-STEMI hospitals.
So if that paramedic didn't do that 12 lead because it didn't fall within county policy and then later develops a STEMI, the untoward effects toward the patient is pretty minimal because of the fact that local hospital has the resources to care for that patient.
Correct. There's still a path for that. And this happens frequently, but sometimes they do an EKG, but it's not diagnostic in the field. And then their symptoms get worse and they're at a receiving facility. And now, as you said, a second or subsequent EKG does show a STEMI at that point, and they'll treat that patient appropriately.
So you had mentioned that acquiring a 12 lead in the back of an ambulance. I imagine that's probably not ideal. Why don't you walk us through like the best case scenario, how you would want 12 leads to be acquired, how quickly, when
Yes.
when you want them transmitted, all that kind of stuff.
Okay. So usually motion artifact causes a bad quality EKG, and that could be from patient movement or patient talking during acquisition. It could also be from the gurney bouncing up and down as the ambulance rides down the road. So that's simply for quality of EKG reasons. You want the patient as still as possible. But the other one that you mentioned as well is when should you get the EKG? And really for anyone who has chest pain or who you start down the path of thinking maybe this is cardiac ischemia, you want to get that EKG as quickly as possible. It's actually a national metric, a quality improvement metric that EMS looks at nationally and that we've started to look at, which is time to first EKG in the field. So from the time you get next to the patient, how quickly are paramedics acquiring that EKG? And the goal, of course, is to have that be as short a time period as possible. Because once you have the EKG, if it's not a STEMI, you still go through your protocol, but you can give nitrates, you can do all sorts of other things to assess symptoms and treat and get transported appropriately. But if you know you have a STEMI, now you have that clock ticking to let's stabilize this patient, but transport as quickly as possible, and it helps you determine your destination and make that call early. You don't want to delay patient care, so early transmission also helps the hospital perhaps activate the cath lab team. So not that many hospitals are activating simply from the radio report, but the radio report in combination with the actual 12-lead EKG that the emergency physician or cardiologist can look at are what most hospitals are using to activate a cath lab. So I would say transmit as early as possible without delaying patient care.
You've looked at some 12 leads in the county and you did some assessment. Can you kind of tell us what you found?
Sure, absolutely. And this actually is really important information. So one of the things that we've started to do in our quality improvement process is get follow-up on patients that we're bringing them for EMS. So we've done this in a couple of areas. One of them is for STEMIs. So I took a look at all STEMIs. We had over 600 for a quarter, and asked hospitals for feedback on those patients. Did they actually have a STEMI? What was the diagnosis? And that kind of thing. It turns out that what paramedics are calling STEMIs in the field, only about 50% of those turn out to be actual STEMIs.
Hold on a second. Can you say that again?
only about 50% of those turn out to be actual STEMIs that the emergency department calls and in the hospitals once they get there. So we took a look at all of those cases that EMS called STEMI, but the hospital did not, to see what the problems were with those.
What'd you find?
Well, a couple of things, and I think these are my big teaching points from this. So poor quality EKGs with wandering baselines have a much higher rate of being interpreted as STEMI by the algorithm falsely, that once you do a good quality EKG, it turns out to be not a STEMI. So poor quality EKGs.
That gets back to patient movement, patient breathing, and the back moving ambulance, all the things we already talked about.
So if we want to be more accurate about calling STEMIs, we have to do better quality EKGs in the field. 1. 2, there are some cases where the EKG did not say acute STEMI, but the paramedic documented paramedic judgment to call it a STEMI and take to a receiving hospital. That in their interpretation of the EKG, they thought it was a STEMI, even though the algorithm didn't. That didn't happen too many times, but every time it happened, it was called a false STEMI by the hospital.
Okay. All right. So it has to say star, 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 STEMI, or acute MI star. So those stars have to be there. If you don't see an asterisk, it's not a STEMI or an acute MI.
Correct.
Okay.
The third thing that resulted in a lot of false STEMIs is, for some reason, some of these calls, patients received 4 and 5 and 6 EKGs. And in all of those cases, the first EKG did not show STEMI, but a subsequent EKG showed STEMI. And that's what the medic used to call the STEMI alert and take the patient to a STEMI center. In all of those cases where multiple EKGs were done and the first one didn't show STEMI, the hospital thought it wasn't a STEMI either.
Okay.
So doing multiple EKGs increases the chances of a false positive. And there's really not, the only reason to repeat an EKG is if the first one is poor quality. There are very few times in that limited 5, 10, 15-minute window of time that the patient is with the paramedics and in transport where the initial EKG would be negative and 5 minutes later is going to be positive. So my strong advice is to do one good quality EKG, and that's it. Stop there. Unless the first EKG is not good quality, and then stop moving the car or adjust the leads, whatever it takes, and get a better quality EKG and go with that one.
Okay. Recapping, the first one was the wavy baseline. So we have wavy baselines. We don't want those.
Right.
All right. The second one is where it never did say STEMI or acute MI, and we're calling those. And then the third one was where we're doing repeated EKGs over and over again. And the first one's negative and the subsequent ones are positive. But I'm guessing that those subsequent ones weren't any better quality, maybe even worse quality, going back to point 1 where wavy baselines are going to be misinterpreted. These monitors at the end of the day are intentionally designed to overcall rather than undercall.
Correct.
The numbers are variable depending upon the manufacturer you talk to, but at numbers as high as 25% of the time it's going to overcall a STEMI because it doesn't want to miss that subtle change that's going on. But because it's designed to overcall, if you give it a wavy baseline, it's going to call that a STEMI every day of the week and twice on Sunday. Well, thanks for joining me today. I appreciate it. Thank you for joining us as well. This has been 5 minutes or less of EMS. We'll see you next time.
Station 51, engine 27, engine 32, truck 105, structure 5.